We move on to our next speaker, Dr. Awais Bokhari, who is consultant cardiologist and has a practice in Harley Street. And his topic is wearable technology to advances in healthcare quality. Dr. Bokhari, please.
Thank you very much for allowing me to participate in this wonderful program. It's wonderful to see Professor Sheena Asif, who's taught me about 40 years back and doesn't look a day older than 25, and obviously my seniors and quite a lot of my colleagues. My role, besides being a cardiologist, is a teacher and a tutor from the Royal College. I'm an examiner internationally, and I've also got a place and passion to develop technical knowledge from a medical point of view, and I'm part of the Google Explorer program. And whatever you see right now is an amalgamation of all these things, which will come to in a little while. So I saw this Chinese proverb the last time we did a talk in Hong Kong, and I'm sure you all can decipher it. What this means is, make me read, and I will sleep. Tell me something, I will forget. And show me something, and I will remember it for the rest of my life. It's the last part that I'd like you to concentrate on. In my talk, I'm going to go through my role as a teacher, as an educator, the evolution of technology as we see it, the evolution of cardiac monitoring, which is my field of device deployment. We present a case report which was held in the BMJ, and how wearable technology has transformed the teaching of cardiac procedures. We will analyze what's been said, and I'll tell you a few future directions in which we are heading towards. And then we'll have some questions. So in my role as a teacher and educator, I get a chance to visit countries which have up-to-date technology, up-to-date infrastructure, where clinical knowledge is disseminated without a bat of an eyelid on technology which is available to everybody. But it also involves teaching in countries where this is not readily available. These may be countries which are third world, nobody has PCs, and that is the reason why we have put forward these kind of things which involve technology to the impoverished too. The barriers for hands-on medical teaching are bureaucratic. People don't get visas to come in different countries to have up-to-date knowledge and education. We have issues of finance, in which people have to sell one of their kidneys to buy a plane ticket to come overseas to do something. We have logistic problems. We can't take the whole theater, a lecture hall, and infrastructure to another country where this is needed. And we have language barriers. And we see this very often when we are holding seminars in especially China or Hong Kong, where language is a major issue. Not to tell about the cultural problems in which there is segregation in different countries between male and females, and you have to repeat the same lecture twice over in the same institution. So how has the technology evolved? We have learned to work and walk from all fours, straight up holding spears, and now we're crouching ourselves down again in front of the computers. The tap that you felt on the stone with the crook in the neck and the bent arms have been replaced by telephones, and we are trying more and more to venture that way. The evolution of personal technology is based on two main things. One is miniaturization, the other one is convergence. As far as miniaturization is concerned, we have tried to carry heavy objects with us, try to deliver whatever is indicated. We have tried to carry obnoxious looking devices. Till in the mid-50s we realized that portability is the key. We started wearing things around our neck, and now we have devices deployed in our ears. The evolution of personal technology, however, has exploded in a big way. It is now a part and parcel of every aspect of our life. It is involved in security and safety. It is involved in the medical field with pacemakers, devices, etc. We have wellness. Who doesn't have a Fitbit over here? I'm sure our children do. Sports and fitness, lifestyle computing, communication, talk about telephones and mobile phones, and glamour, LED monitors being worn, high-tech clothing being worn, which changes color in different light. But the convergence is one thing which has moved technology in a big way. In this graph by Gary and Hayes in 2006, our mobile phone now contains our projector, camera, fax machine, computer, television, and you name it, it's got it. But how has technology evolved in the medical field? This is a dated slide in which technology was used to make sure that your colleagues hear the heart sounds adequately. We have evolved techniques in the operating theaters where initially the patient used to be as if he's in the amphitheater, the center of all attention, and the participants operating while the onlookers peering over counters. This changed, evolved in the mid-30s to people looking over the patient itself. That led to quite a lot of disasters, not at that time chewing gums, but nuts, vomits going in the patient's cavities. Therefore, we moved the audience away from the patient. We moved them higher up, but still looking at what's going on. We have still intraoperative approach in which a surgeon has to teach everybody or as close as possible as to what's going on. To now, we have installed surgical barriers in which infection is not transmitted and the people can have a bird's eye view of what's going on. This is the current typical intraoperative broadcasting setup where you can see there are a lot of cameras. Obviously, the cameraman is peering over myself over here to see what's going on. It's clearly not satisfactory. The evolution of cardiac monitoring has also come a long way. We do patients' ECGs. So every time somebody has a problem, he can't go to the hospital to have an ECG done. And therefore, we evolved a 24-hour or a 48-hour ECG monitoring in which the patient wear a device around their neck. We have moved forward for event monitor. So whenever the patient has a problem, he puts the monitor on the chest and it records and transmits the data. We have evolved the R-test, which is currently the state of the art in which the patient wears this device and it records it for a good 1 month. The patient can take it off, patient put it back on. And in my line, an implantable loop recorder in which we can implant the device under the patient's skin and records the patient continuously for 3 years. And the patient can just put the telephone on and transmit the data whenever he has the symptom. So let's look at a typical case of what happened. This young lady came over to us. She was having a tough time being an air hostess. 20-year-old, had palpitations, and she used to faint, not daily, but occasionally every 3 or 4 months. She had episodes in which she was lying down and she used to get up and she used to faint, and she was investigated thoroughly. Obviously, she went through an ECG, which was reported as normal. She had a normal echocardiogram, which reported essentially normal cardiac structure and function. She had a normal 24-hour ambulatory blood pressure and ECG monitoring, which did not reveal any evidence, but then she did not have those symptoms that day. We also had a 24-hour ambulatory running monitoring and 72-hour monitoring, which, surprise, surprise, had a very good day that day and did not reveal anything. We gave her a cardio memo so that whenever she is about to faint, she can put it on her chest, but lo and behold, she fainted and did not have the time to reach for the device. And the R-test, which was given to her for a month, did not reveal because she had a very good month that time. So one option was, now came the time that I should give her a loop recorder. Deploy the recorder under her chest, which will reveal the data over to us and periodically whenever she gets the symptoms. Now, this lady is a very slim lady. If I deploy the device under the skin and she feels it, she's going to curse me for the rest of her life. Not mentioning that lead is a keloid scar. So this was a time to have a newer, much smaller, injectable, implantable loop recorder, which was being trialed in the USA. This device was not available in UK at that time, so it was felt it would be a good candidate to deploy this device and see how it happened. After a consenting procedure, which took less than a minute, because we showed her what was to be deployed in compared to what was being deployed previously. So this is a good comparison. On your left is a normal 50-plus-year obese male, and on your right is a form of this young lady's body habitus. So these are the two devices. We were opting for the device on the right. If you look at the device in real time, this is the comparison. So the device was chosen. How do we deploy the device, and how do we make sure that I can impart this technology, this procedure, and the procedure itself, along with what comes with it, to my colleagues and to people around the world? So putting it all together, we decided to deploy this and transmit it. We gained appropriate information from our broadcasting people, and we thought about convergence. At that time, I bought a device called Google Glass. It was a glass, wearable glasses, which has built-in camera, heads-up display, internet connectivity, and broadcast features with Bluetooth and Wi-Fi. So the setup was very simple. I gave it a try of using Google Glass and transmitting it via Bluetooth initially as a trial purpose. Then through the N3 secure network, decided to stream it all over the world via our internet and hospital facilities. The pre-op evaluation was done, a proper consent was taken to broadcast it, and I wore the glass to transmit this procedure. This is me on the day of the procedure, a bit apprehensive, but you can see the Google Glass on my eyes over there. We did a transmit trial run, and here's my registrar having a look at the Bluetooth transmitted over there. And while I'm doing the procedure itself, it was on his telephone. You can see a first-hand view of what's going on. We then transmit the data all over the world while we are doing it. And this was received internationally in different centers. We published this in BMJ, and we had a novel title of Novel Treatment, New Drug Intervention, Established Drug Procedure in a New Situation, and was published with great response from public. So the analysis was, this technology is deemed useful. It is not obstructive in any way. Because I wear glasses, I had to modify the glass to my, my own visual needs. And here's the data. And you can see over here that in our hospital, 130 people used it. Internationally, nationally, 115 trusts use it. And internationally, this is the data. I'll switch on to the last one, last slide of the picture, which is, since that time, this has been used, our technique has been used in disaster areas, in orthopedics facilities also, and it's been gaining much more attention. Now, the ethical issues with regard to DMC was that we had to have a proper consent to record, transmit, and store this data, which we did. Lastly, but not the least, it is a technology which is here to stay, and there is no reason why this can't be deployed. We got a letter from a guy who is in Central African Republic. Thank you for showing us this procedure. I felt I was in the operating room. I have never visited any other country in the world, so having the chance of being the operating room with England with you was such an experience I will never forget. So remember, show me something I will remember for the rest of my life. This is what technology can do. Thank you.
If there are any questions, please kindly raise your hand. So I think, thank you very much, Awais, for, yeah.
£1,200. But if I transmitted this from a hospital setup, it would be in the cost of about £10,000, and that too within UK, not international.
Can you just hold on? There's one question on the floor before you go.
You know these head cams that you have? They're only about $50 or so. Will they not do exactly the same?
They could do exactly the same, but then you have to be dependent. They're not Bluetooth linked, number one, if you want to do it locally.
Yeah.
And number two, the field of vision that you have from my setup, they're very intricate connections,
Yeah.
which these do not transmit. We've tried that also, by the way, which is GoPro cameras, etc.
Yeah.
But they would not begin. They've got a wide field of vision rather than narrow field of vision. We wanted a narrow field of vision because our devices are very small.
Yeah. Thank you very much.
Thank you, Awais.
Thank you.